everyone. Welcome to Macleods Medlive Expert Opinion Indian Perspective. We are at RSSDI 2019 being conducted at Jaipur, Rajasthan. I am Dr. Rahul Kotwal from Medical Affairs, Macleods Pharmaceuticals. Today we have with us Dr. Anil Virmani, who is a consultant cardio-diabetologist at Jamshedpur. He had his session on clinical approach to diagnose diabetic cardiomyopathy. So sir, I humbly request you to summarize your session for the benefit of our fraternity.
Hello Dr. Rahul, first of all.
Thank you.
Diabetic cardiomyopathy is one of the most challenging and difficult diagnoses to make in contemporary cardiodiabetology, for the simple reason that these patients are often asymptomatic and silent in the initial stages. Basically, it has been defined as the presence of structural and functional abnormalities in the cardiac myocyte in diabetic patients in the absence of traditional risk factors like hypertension, coronary artery disease or valvular heart disease. The problem comes that if you look at the pathogenesis of this, in the initial stages, when the whole metabolism is disturbed in the cardiac myocytes and there is a shift from glucose to free fatty acid levels, free fatty acid utilization, which we all know is metabolically inefficient.
Yes.
What happens? That is the initiator of diabetic cardiomyopathy, where there is left ventricular remodeling, there is changes in the left ventricular cells, there is apoptosis, and there are so many signaling, insulin signaling abnormalities. At that particular stage, the disease is silent. We do not see any structural or functional changes like diastolic dysfunction. The earliest change to occur is strain, the defects in the strain and the stress of the left ventricle, which can be diagnosed only on strain tissue imaging, which is hardly done by anyone in our country. So, and these patients are asymptomatic. That's the problem. And then these patients gradually progress to, they present with diastolic dysfunction in echocardiography. They may remain asymptomatic and then they may land up into heart failure with preserved ejection fraction and may again be difficult to diagnose.
Yes.
Ultimately, if we still do not diagnose these patients, these progress to systolic dysfunction and heart failure with reduced ejection fraction, where they are normally picked up by the cardiologists. But the message that I want to give you is, since we cannot catch them in the earliest stage, at least when we should have a very high index of suspicion in patients of diabetes, especially more than 5 years duration, who present to us with vague symptoms of fatigue, breathlessness, pedal edema, and we get a lot of these patients.
Yes.
And once we have that high index of suspicion, we must try to investigate them by ECG, by 2D echo, by the pro-NT-BNP levels to see whether they are high-risk cases for heart failure and heart failure with preserved. Unfortunately, we know that when NT-proBNP level crosses more than 125, it is diagnostic of heart failure, but even normal levels do not rule out diabetic cardiomyopathy. So that is the problem where the whole crux lies. So we should be diagnosing them when we suspect diastolic dysfunction and going for echocardiographic and pro-NP studies. There are a lot of other diagnostic modalities like cardiac magnetic resonance, spectroscopy, tissue Doppler imaging. Unfortunately, these are very neither accessible nor affordable for our patients.
True.
So the treatment is basically lifestyle directed, the balanced calorie intake, regular exercises. When we are treating the diabetes part, we should treat them with the novel cardiorenal protective drugs like the SGLT2 inhibitors and the GLP-1 receptor agonists, especially liraglutide and dulaglutide. And when we are treating patients who land up into heart failure, the treatment of heart failure is guideline directed, independent of the presence or absence of diabetes, and should be on either RAS blockers or preferably the angiotensin receptor neprilysin inhibitors, the beta blockers, the mineral receptor antagonists, and so on, and the judicious use of diuretics. So these two, a combination of this high index of suspicion and the proper treatment for diabetes and lifestyle, and then of course treatment for heart failure, is what all we can offer to our patients at this stage.
Yes.
The future we are looking at microRNAs as novel biomarkers to catch these people in the early stages. Thank you.
So thank you, sir. Thank you very much for summarizing the whole session into such beautiful words. Thank you. Thank you very much.
Thank you.